Hello, everyone, and thank you all so much for being here. I'm Tori, Senior Client Support Specialist with CE Zoom, and we have a wonderful webinar for you tonight. Before we begin, I do just have a few housekeeping items. First and foremost, just as a reminder, this is a webinar, so it will require a good internet connection. If for any reason you get disconnected, our best recommendation will be to try to reconnect using the link that you used to get here. There will be a chat box to the right of your screen. Feel free to use this to talk among your fellow attendees, make any comments. We will also utilize that box to share important information with you throughout the webinar. We will have a Q&A session at the conclusion of the course with our speaker. So that is a great time to ask any questions you might have, and you can use that Q&A feature at the bottom of your screen. At the conclusion of today's course, we will be sharing a verification code, and this code will be very important in order for you to get your CE certificate. You'll return to CE Zoom, log into your account, and scroll down until you see scheduled live courses, expand that section, and a verify button will be there at the end to enter that code and take the survey. Once those steps are taken, your CE certificate will be right in your account for you, both on your dashboard as well as under My Certificates. I'll also repeat those steps at the end when we share that code. We'll also share a resource for you if you have any trouble. But for now, I would like to turn the time over to Greg. Hi, Greg.
Hi, Tori. Thank you. Welcome, everyone. From Brasler, we're proud to present Dr. Meza. Dr. Meza is a published researcher during his residency on YSGG, and we'll be talking about utilizing YSGG with low energies. Thank you, Dr. Meza. Welcome.
Thank you so much, Greg. And hope everyone can see my screen at this point. Appreciate the opportunity to both see Zoom and Brasler for allowing me to give you about an hour's worth here of a webinar tonight at the end of the summer here. So I'm Dr. Meza. I have a practice in Arlington and Alexandria, and that's our name of the practice, Arlington Alexandria Laser Endodontics. And tonight's webinar is going to be on embracing low energies with YSGG laser-assisted endodontics. And just a couple disclosures right at the beginning here. There is commercial support for the CE program was provided by Brasler, so I am receiving an honorarium for this webinar. And thank you again to CE Zoom for managing this as well. Disclaimers as well here for you to read here, some clinical procedure methodologies. These are just very safe things that I've been using in my practice, and as I've had almost 5 years of laser endodontic practice. But again, these are some disclaimers for you just to present up front. Course objectives. So we are going to hopefully demonstrate to you tonight how to manage calcified canals, how to use low energy settings as well for desensitizing hot molars during access. We'll also be looking at minimizing bleeding and ledging in the canal as we do laser endodontics, and also demonstrate through some videos as well why laser tip placement in the canal is a critical step for endodontic treatment. So kind of similar here in the agenda, and I had a little catchphrase, low is smooth and smooth is fast. It's actually really more smooth, slow is smooth, and as you'll see in the next slide here. But essentially we'll be, again, just doing a little intro. I'll discuss some laser-assisted endodontics, laser-assisted irrigation cases, some concepts, and again, the objectives for tonight. So laser-assisted endodontics, what is that? LAE. Well, apical patency, dentin conservation, predictable healing. These are some of the most important advantages that come to mind as I've used laser now for all these years at this point. So I picked this little slogan here, and I kind of modified it a little bit and just said low is smooth and smooth is fast. What I mean by that is that the whole entire webinar is on essentially trying to use lower energy, 15 millijoules. I do realize that the Edge Pro is a 100 millijoule unit, capable of 2 watts at 60 microseconds. And so I know a favorite setting is 25 millijoules, and I just wanted to show you some techniques that I've used very convincingly at a lower energy, and I'll explain why. But just to dive in a little bit more, you start slow and it's deliberate and controlled. That gives you precision and consistency and reducing errors, and therefore your improved efficiency, and you execute faster. So that's the kind of the whole idea. All right, so just to back it up a little bit, just to compare traditional endodontics versus laser endodontics. On the left-hand side, you'll see instrumentation. On the right-hand side, you'll see irrigation. These are two kind of competing sort of ideas that kind of at that level. You'll see the next one is file focus versus tooth focus. So I'd like to think that in laser endodontics, we're actually more focused on the tooth, meaning conserving tooth structure, versus in traditional endodontics, we're more focused on instrumentation, getting it large enough so we can then place our irrigating solutions down closer to the apex to avoid vapor lock and such. Those are just kind of the ways I think about it in my mind. Of course, common to both is, of course, debridement disinfection, a major goal in endodontic therapy. I like to say that in laser endodontics, because things go smoother, things go faster, treatment duration is shorter, that we like to try to do single visit mostly, and versus in traditional, time being a factor and maybe unable to clean it as properly could lead to multiple visits in more cases. Of course, will I do some multiple visits? Yes, on occasion I will, but the majority is single visit. Some of the disadvantages, I kind of went over some of these but in the traditional, you have some disadvantages as greater canal taper and apical enlargement, requiring more files. Of course, you have vapor lock and some compromised syringe irrigation and ultrasonic tips, which can, once touching the walls, can decrease their effect and hence really lead more to acoustic streaming rather than cavitation in a lot of canals. Of course, then you've got longer duration of treatment and, of course, the multiple visits. Moving back to laser endodontics, you have enhanced and effective irrigation for once, greater dentin conservation, as you'll see in some cases I'll show pretty soon here, decreased treatment duration, and single visit. And so those are some of the advantages. Here's a case that I did on a patient, and you can see access is rather conservative. I know you can go even more conservative, as you'll see in the next slide. But I mean, if you can just think about this, this is a case that had a small little crack starting. So we definitely crowned this tooth. However, if we had a younger patient, for example, and there was no crack, it was just maybe a composite that was close to the nerve potentially. I think these days with conservative access and minimal instrumentation, I think it can lead itself to maybe just an occlusal restoration, like a class 1, for example. So moving to ultra-conservative endodontics, Dr. Banch, Francisco Banch, I know on Instagram, he's posted numerous cases, and as you can see, access here is even smaller, as you can see, and so it just gives you a taste of what you can do with a laser, such as the Edge Pro, or an Edge, a Waterlaze, or with from Biolace, all the same energy, basically. Pretty amazing what can be done, and he's got great follow-ups on healing. So it is very possible to do this. These are some of my cases that I've done over the 5-year span, including some more recently as well. As so those of you who have seen me lecture before have potentially seen some of these already, but there are some new ones as well. I try to recall some of them 6 months later, or as much as I can, really, just to prove that to myself that this is working so well. And so this is a case number 20, a very conservative access. It was an irreversible pulpitis case, and 18 months later, it's holding up real well. I can't say the same about the implant next to it. That seemed to have some peri-implantitis. But again, I think the name of the game here is conservative endodontics, minimally invasive, and what can we get away with here in a single visit to treat teeth. Here's another case that when I think about it, how is it possible that I could irrigate this with just syringe irrigation? It was about a 26 millimeter to 27 millimeter working length. I'm just not sure how you would necessarily get syringe irrigation to go downwards to the end of the canals here, the apex, on a tooth that's this long and somewhat calcified, maintaining conservative endodontics. Here's a 6-month follow-up. Again, I feel like that's conservative. You could even go even more conservative, but here's a case of 6 months where you can clearly see that the periapical lesion has decreased in size and almost healed completely, at least on this view. Here's another case that looks like to be calcified canals to start with. It almost looked like one of those J-shaped lesions, but probing depth was not there, so it kind of looked like that, but I went ahead and treated it with high hopes, and lo and behold, 6 months later, it's doing quite well, as you can see with the healing. Here's a very recent case of a retreatment, and this just goes to show you what you can achieve sometimes. And I want to say this is due to laser endodontics. We talk a lot about laser patency, and what you can see here is kind of like ledged, previous instrumentation. How are we going to get around this? So my pre-op and post-op, immediate post-op's on the left, on the lower left-hand side. You can see, due to the sealer puffs in the area, that I wasn't able to necessarily instrument physically with a file, but I'd like to say that some of the irrigating solutions have made an effect here, and been able to render, at least 6 months later, some healing of the case, as you can see on the right-hand side, on the top and bottom, with those different views. Here's a pretty neat case on a number 29. The top views, all top views, are my pre-op and immediate post-ops, and 6 months later you have some healing, as you can see on CBCT here of number 29. Very nice on the coronal to see all that healing, especially on the buccal plate, and as you can see on the PA as well. Here's what I like to see all the time, like full, complete regeneration. It's like magic almost. And so here's a retreatment case. And again, these are all single visit cases. Retreatment case where you have your pre-op and immediate post-op on the top views. And then I have a 8-month follow-up here with CBCT. And as you can see on the coronal view, again, that mesiobuccal root that had almost an eroded floor of the sinus has come back like nothing ever happened. So that made me feel very good, of course. Here's another case that just kind of blew me away as well. I would have thought this case was going to have to be an apico for sure afterwards. And we did a 6-month follow-up on the case, and I wanted to do a CT as well, just to see if any of that had healed. And when I took the X-ray, I was immediately gratified, and I said, well, if we can do that CT, I'd like to do it just to verify that, because it almost seemed like we had a through and through defect here. And amazingly, we got plenty of bone here, and I'm happy to report we did not need to do an apicoectomy on the tooth, and that remains till this day. Here's another very recent case of great healing again. I like to think that's pretty conservative case, and there's your 6-month follow-up. I'd like to thank Dr. Barnett. He's been on using lasers in his program since longer than I have, maybe 6 or 7 years, possibly at this point, maybe longer. I know I've had 5. Anyway, he has sent me some cases of his residents. Dr. Tom, these are some amazing cases of residents. I mean, if I had this tool in my residency on patients, I actually did have it, but it was just not available for me on patients. But you can see the amazing work that these residents are doing, and the ability of cleaning these teeth it's just a whole nother level. I went ahead and just wrote down some little catch phrases down below as to what he's using in the majority of these, because he had sent some other cases too, but I thought these were great cases. Tip 1, tip 3 is used quite a bit. Coronal conditioning, which is kind of chamber photoacoustics with irrigating solutions or even water through the handpiece. There's continuous as well as intermittent irrigation, which I'll discuss and talk about a little bit more. And of course, we're using the Edge Pro unit YSGG laser here. All right, so this is an older video that I did when I kind of got started on lecturing for BioLase at the time, and I'll play it for you now. But what's interesting is that photoacoustic effect is real. If you think about it, you're talking an order of close to 500 watts peak power every time that laser pulses And it's a tremendous amount of energy, and you can see the effect of this go all the way down to this the solution inside here, which is an acrylic block. So I'll just play it for you now, and you can appreciate some of the activity going down pretty deeply down this narrow sort of acrylic block space. All right, so as you can see there, that's an RFT2 tip at 25 millijoules, 1.25 watts, and 50 hertz. You can see all the activity. There's a vapor bubble initially at the tip, and you have secondary cavitation bubbles and activity that moves fluid and creates secondary cavitation bubbles. There's three effects, largely speaking, in endodontics with laser-assisted endodontic. There's a photoacoustic effect, which I just showed you, and that's just agitating, irrigating solutions. There's a photothermal effect that, again, is sort of light energy transforming to some heat. And of course, there's ablation, and that's really more like vaporization or cutting of tissues. It's really just kind of like a vaporization of soft tissue or hard tissue right in front of your own eyes. And this is due to really incredibly high peak powers and the way the laser runs with the pulses and the hertz that we use and the wattage that we use on the unit. Just to kind of review a little bit, there's two effects with photoacoustic effect. There's an acoustic streaming, which is more of a wave causing directional flow velocity. There's also cavitation, which is more a pressure wave causing bubbles to grow and collapse and release jets. These are all important in moving debris, disrupting biofilm, so you can then flush it out more easily with your syringe irrigation, as we do in intermittent, as well as in continuous irrigation. So think of it as the laser as the perfect sort of power washer or washing machine effect within the canal system. And that's really what I think we were missing back in the day here with traditional endodontics. We thought we were getting it with ultrasonics, but we're just not possible to get the level that we do with the laser tips. And we're also not hindered usually by the instrumentation or the minimal approach at all, because you still get a robust cavitation and acoustic streaming effect and really tiny canals. All right, so we'll talk more about that a bit later. Here is an example of an extracted tooth that I did, a little video I did for you just to appreciate more that photoacoustic effect. This is a tip number 1. It's an RFT2 tip that's going to go into a mesiobuccal lower molar here. And then you start to see the bubbling. So what we're having here again is a transfer of light energy and into bubbles, cavitation bubbles that are allowing debris and forces to move debris and disrupt biofilm and flush out your bacteria. There are 4 essential ways that we have laser interact with tissues. I'll just go over the examples, but we have transmission as one, absorption as our one that really is what we see, in front of our eyes. Scattering, which is more so with like lower level light energies like photobiomodulation, and reflection, which I'll kind of review a little bit for you and why it might be bad for us or not effective for us using our laser unit. So first is the absorption. This is what's interesting to us. This is what allows us to ablate tissues and vaporize them in front of our eyes. Of course, you have, when you put solutions in canals, then you're going to have the photoacoustic effect that we love to use. And I think what's happening here is that we're just really potentiating our hypochlorite solutions and EDTA solutions. It is true you can get smear layer removal with just water, but it's just so much more efficient and effective when actually using the solutions. And then you throw in the laser and the photothermal effect, you're warming the solutions, they're just much more effective. Transmission, there's 2 examples I can think of. One is in the ophthalmology, and isn't it amazing that you can use a specific type of laser, in this case, in the 532 to 67 nanometer wavelength, and just goes transmit right through the cornea without damaging it whatsoever, and hitting little vessels of which chromophores are hemoglobin and oxyhemoglobin at the back of the eye and the retina to cauterize them and do all nice kinds of treatments. Same thing here, where you can transmit light energy right through the ceramic, all ceramic crown or veneer, and then of course the water absorbs the water-based cement absorbs the light energy to decompose it, and then you can take the crown off without damaging it. So these are two examples of transmission initially, and then you have absorption at the correct wavelengths for your chromophores, water being the one for the water lays, the YSGG. Or I'm sorry, as well as the Edge Pro. It's the same wavelength. Photobiomodulation is just lower light energy, low level light energy. It's another way to describe it. These are effects that happen more at the cellular level, and they are responsible for increasing ATP, promoting vasodilation, inhibiting substance P, and all kinds of mediators of inflammation. So it brings the best out of inflammation and decreases pain at the same time. So it just kind of fast tracks healing, if you will. And this is very important too for potentially other items of research in endodontics, for for post-op pain perhaps. So very interesting interaction here as well. Lastly, the interactions, we have reflection. What I've done here on the right-hand side is show you a laser tip fiber, and you can see on the very top, looks like a moon there, half moon or something. That's a mirror, and it's a concave mirror where you get reflection from the laser source, and as it goes into the fiber towards the top end that goes into the handpiece, you can see reflecting beams of the light energy. And then of course you have, because you have the conical beam at the end, you have this donut shaped distribution of the aiming beam. And then once you hit the pedal, it'll have the actual energy. And what can happen there is sometimes you can get backscatter because potentially maybe from overuse, or you've hit the tip too many times on the wall, you can damage the conical tip, and then you won't have the laser light may go back inwards in through the optical fiber or the tip, and then cause a pitting or damage to the mirror. So that can go further and even damage a trunk fiber. So always make sure you have a nice aiming beam shown here, because that's just kind of indicating to you that once you actually deliver the invisible 2780 nanometer wavelength from the YSGG, that's your target area, and that's what you should see. All right. So just for you to appreciate also, I want to just show you here. So the Edge Pro is a 60 microsecond pulse every time. And that's an H mode only. If in the water lace, you have a situation where you can do S mode, and that's 600 microseconds. So that's 10 times longer. But I wanted just to appreciate how short 60 microseconds is within a million microseconds. And I kind of drew a little timeline here just to demonstrate. If you expand the second tier, you can see all the way from 0 to 15,625 is just that little bit there, drawing from the top one. And then on the bottom, you exactly see where 60 microsecond lives. And it's just amazingly short amount of time. And within a second itself, you have 20 hertz. That means that there will be 20 pulses of that 60 microsecond duration pulse 20 times in 1 second. And if you add that up, it's about on for only 0.12 percentage points of the time within that second, and 99.88% of the time it's off. What ends up happening here is because you have very, very short 60 microsecond durations, you have a very high peak power, and that's what allows for ablation and the photoacoustic effect. At 600 microseconds, your peak power is diminished significantly, and so is your photoacoustic effect. And also your thermal relaxation goes down as well, because the laser is on longer, and it just may heat the tissues more. All right, so this is what a slide that I like to talk about in terms of what is a good range of millijoules, because I know the Edge Pro has pretty nice talks in millijoules. I like that. And you can, from my experience, I believe that 16.7 or 15 or 10, as you'll see in the next slides, is a good number to be at. And as a low range, and then a 50 maybe more towards the coronal aspect of the canal, and then 75 and 100. I really kind of believe those should be more left to the pulp chamber. As you know, you can take watts and divide it by hertz, and you multiply by 1,000, and you get your millijoules. That's how you get these numbers up here, like 50 or 25. Tip 1, as a reminder, is a 200 micron diameter tip, and tip 2 is a 320 micron diameter tip. And interestingly enough, tip 2 has what we call a calibration factor, so it's actually 85% of what it states. So it's roughly, if it's 50 millijoules that you're using, 85 times that, it's going to be roughly in the 40, 35 range, more or less. And if you're using a tip 1, if you're applying 25 millijoules in the canal, as we do usually, then we're going to get closer to maybe 12 or 13 millijoules actually in there. I wouldn't make much of that, except that, just get a sense of 25 millijoules seems to be right. My entire lecture here, as we'll see, is more about lower energies, such as the 15 millijoules that we'll talk about. So this is kind of like this is kind of like the lower energy piece. I did have this table here for you to show you 10 millijoules, 15, 20, 25, 30, 35. These are all possible on the Edge Pro. And what you'll notice is that if you go up and down on millijoules, either the hertz kind of changes or the watts change. And a lot of times the watts will go up in increments of what I listed here under the common difference. Every time you go up, it'll go up in that increment. And so the idea here is to try out a lower energy setting, which is 0.3 watts over 20 hertz. And that can be done on the Endo Geek mode. Benefits of this lower energy is that you get no splashing, as you'll see with intermittent irrigation. And you get effective use of, so you get more of an effective use of the intermittent irrigation. There's a better visualization of the photoacoustic effect. And because of that, you don't require simultaneous suction, and it's actually quieter. And I also believe there's an added benefit of warming the solution. Here's what it looks like basically at this point. Just want to check on my time here for a second. So tip 3, as you have it there, 500 microns. That's kind of a blow up of what it looks like. Tip 2 at 320, and tip 200 here. Tip 1, sorry, at 200 microns, and just gives you an idea of what it should present with prior to using it in the tooth. Here we're talking about dentin ablation, and if you read a few articles, it'll talk about fluence, which is your energy density. That's energy delivered per unit area. And you have a dental ablation that kicks in about 3 to 6 joules per centimeter squared. And as you can see, our current energy settings that we use at 25 millijoules is between 8 to 11 joules per centimeter squared. So we're kind of above the threshold here. And I think that's one of the reasons that I wanted to lecture on this, because I want to offer the alternative of the 15 millijoules, which you'll see in the next slide, offers a closer range to that dentin ablation range. And I think that will help out for practitioners that have potentially had an issue with ledging in the past, or maybe solution splashes out too much out of the pulp chamber. So I'll just kind of we'll go in more depth of that. So there it is, your 8 to 11 joules per centimeter squared. It's obviously high compared to the threshold for dentin ablation. Here we have the 15 millijoule version, and as you can see, we've dropped from 8 to 11 to 4.5 to 6.5. So that's a little closer to dentin ablation. Still potentially higher, but less of a chance to cause a ledge, perhaps. And a lot of the cases that I'll show is going to talk about this level of, at this energy, how it's useful to manage calcified canals. So here we have what I think is the what, which is laser-assisted endodontics, and that's apical patency, dentin conservation, predictable healing. And the reason, and the how and the why, I believe it's just because we're activating this sodium epichlorate with the laser, and it's allowing for enhanced tissue dissolution, debris removal, and disinfection. Here's a video of just some continuous irrigation, and you'll notice a little bend of the needle that I typically do, and that's just to make it easier for the assistant to deliver even hypochlorite solutions, and without placing the tip into an orifice of a canal. So what you do here is you bend that tip here, like that 5 millimeter bend, and this allows you to put any volume of syringe on there, and be pretty effective. Of course, I always test it first to make sure that the solution's running freely in there, and I place it into the occlusal surface, occlusal cavity of the endodontic access, and I test it first under microscope to make sure I'm not close to any orifices. And if it works out fine, then I give it to my assistant. And oftentimes I will use saline even to practice. Here's another example of continuous irrigation where it's just from Francisco Banch, a video where he just kind of shoots it right above the occlusal surface, and that's effective as well. He has great, isolation there, and I'm sure the assistant's doing a great job of suctioning that. But I like to place mine into the occlusal surface as well. I just think that makes it maybe sometimes a little easier. So managing calcified canals. This is an important one for endodontists. Let me just start playing the video. But essentially, this is a technique that I was able to do with 0.5 watts and 30 hertz, which gave me about 16.7 millijoules with MZ59 tip using the Water Lacite Plus. I can do the same thing here with the Edge Pro, and I can use 0.3 watts over 20 hertz, giving me 15 millijoules, our lower energy setting. And this is kind of how I use it. It's kind of like an intermittent irrigation. Place the irrigating solution here, in this case, sodium hypochlorite. And I just kind of bounce up and down on it gently, right above, even touching the floor of the pulp here, as I allow the laser light energy to agitate the solution. And here we do some syringe irrigation. And now you can see now in higher power under the microscope, we're starting to get a little hint of the canal opening up, and this is our everyday kind of thing, right? I mean, we're constantly fighting these MB2 canals, and they're very tight to begin with, but this offers you, I think, a way to get the case started. And the reason I like this using the tip 3 is because you're just not likely to get an RFT2 tip 1 inside anywhere close to that orifice, and it just won't be as effective, in my opinion, because the cavity, the chamber is too big, and then you also got the calibration factor that you're worried about diminished. So and because it's a small tip, it can deliver a lot of energy density, and so you can risk a ledge. Versus if you use tip 3, which is the 500 micron diameter, you're going to be the ledge potential is way down, and now you can again just use that energy, light energy, right there on top, as you can see. Again, repeating the step, which is just kind of even making little touches right above the orifice, gently up and down motions. You don't want to bind the tip, obviously, into the orifice once opened, but it's always got to be loose. And if you touch it gently for a split second as you bob up and down on it, it's going to be fine. As you can see, I've done that. I've touched the floor of the pulp with making sure there's solution inside. And you can see how I'm not really getting ablation of the floor there, and then I'm doing quite well with opening up this orifice. So here's the case towards the end here, and we filled it. And tip 3 is what was used there on the what can be used here. It's an equivalent, I think, for this use for managing calcified canals for this case. Here's a couple other cases where tip 3 can be used. And again, the beauty is there's no splashing. You just flood the chamber, or what's left of the chamber, with the irrigating solution, the 3% hypochlorite, and you just agitate the laser tip on top as so, and then just start negotiating with your files. Here's another case, as you can see, extremely calcified case, no splashing. You just place it. You place the solution in that little cavity, and then you just apply the tip in there, moving up and down gently. And I do this for about maybe 10 seconds, maybe 20 seconds. Then I flush it out. I suction it using a microsuction, and I look again under microscope to see if I've had any progress in it, and usually it ends up helping tremendously on this. Here's another calcified case. And this is, again, lower energies, which you can expect with intermittent irrigation without the canals, the solution splashing out so much. You can see on higher power how nice the canals can look, and you don't have any ablation of the floor of the pulp. As you can see, these lower energies are quite adequate to render things clean without ablating the pulpal floor. As you can see there, again, very clean floors, no ablation, and it's very effective. So again, 15 millijoules is a great one. So moving to desensitizing hot molars. Sorry, I'm moving quite fast just because I have so much to cover, but here's an interesting possible mechanism described by here Polonsky, Dr. Marina Polonsky out of Toronto. She's used lasers for very many years and speaks frequently on lasers at WCLI, which I've attended many times. So she, in this study, which she participated in, she basically, used the laser at 2.5 watts. This was the water laser at 15 hertz, air and water 6080, and pretty much created cavities 0.5 to 1.5 millimeters into dentin of carious teeth, and they were rendered pain-free without local anesthetic. So there's some potential mechanisms of action why this helps or why this works. And some of it could be melting of the peritubular dentin, thereby occluding dental tubules, or also the photoacoustic effect that interferes or destabilizes action potentials of neurons. So how I apply this to a hot molar is, first of all, the patient is way anesthetized. I might have even done a PDL injection, perhaps. I don't really use much intraosseous, but this works quite well after a PDL injection. And so it's a non-contact mode. So I'm kind of hovering over the access cavity that I've done for my endodontic access, where I started the case with a burr, and all of a sudden patient says, I feel it. And so what we're going to do here is apply the 0.3 watts over 20 hertz, the same 15 millijoules, using tip 3. Important that the air and water is off. And what you do is you just hover over the access prep for about 10, 20 seconds. Then you move up and down in a gentle circle inside the access prep itself. And then you try the access with the burr again, with water. And a lot of times patients will just not feel it, and you can get deeper into the prep. And if you need to repeat it, just go ahead and repeat that first step, the hovering over the access for 10, 20 seconds. And then you can, again, go with the burr. And it's pretty amazing because at the point where they actually do really kind of feel it more is right when you've opened into the pulp. And there you can just give your intrapulpal and get on with the case. So I found it to be quite useful. Of course, I've numbed the patient. It's one of these things where, like, I've numbed them a lot. I don't know what's happening. I've given a PDL injection. I can try this, and it works quite well. So I want to show you some videos here, but moving on to other topics, which is importance of placing the tip in the canal. Boundaries make a difference, and there is increased pressure when the tip is placed in a more confined space. So obviously it's all about physics. It's the seconds, it's the time that you spend with the tip inside the irrigating solutions. It's how close you are to the apex, your target tissue, and how much energy you're trying to deliver through the tip. But what about boundaries? How do those have an effect? And boundaries could be, in our case, a large or small canal to begin with, a large or small pulp chamber to begin with, or maybe you've opened your endodontic access, maybe smaller than usual or larger than usual, depending on caries or no caries or minimal approach, as well as our canal preparations there too. So some of you that know me, I do tend to dabble a little bit and tinker a little too much maybe, and I have what I call here the Garage 2 shop. That's actually my my global from residency. After I upgraded in my office, I decided, well, I have an extra microscope. I'm going to take it home, and I've actually hung it up in my garage, and that's kind of where I do some of these interesting little studies and have fun with teeth. So based on all that, using the garage shop and going back to the office and crafting this little mechanism here is I put a tooth here. And this is an important video in that it shows you the difference of what happens when the tip is placed in the chamber versus what happens when the tip is now placed in the coronal aspect of a canal versus what happens when the tip is placed all the way down the apical region. What you got on the left-hand side is a water column. And what you'll see here is I'm going to place the tip first in the chamber, second in the coronal, and third in the apical area. And I want you to look at the water column on the left, how quickly that rises. Now, I want to stress that this is a clinical setting where we just don't see hypochlorite accidents, but you see enhanced pressure. And I guess this is a way for me to show you how there's enhanced pressure that's going to be felt against the walls to move debris and disrupt biofilm by placing the tip in the canal. Now, interestingly, you'll see that there's cavitation or secondary cavitation at a distance all the way to the apical region, even just when placing it in the chamber, but you'll see that that effect increases as we go down into the coronal and the apical. So here's the start of an RFT3 tip, and we're going to place it in the chamber first. And this is an energy that, again, you see won't splash out of the occlusal, so it's on the lower end. It's maybe about it's about 30 to 25 to 30, that range. As you can see, not much difference in the water column, but watch what happens to the left water column now that I activate the tip. You see we have increased pressure in the system, and you therefore see an increased rise of the water column. Now we're going to do a withdrawal apical, and you'll see the water column go even faster up. And again, this is a loose placement of the tip in the apical and also in the coronal of the canal. So we don't have hypochlorite accidents at these levels, 25 millijoules or even 37.5 and even 50 perhaps at the orifice level. I don't recommend anybody to be using 50 millijoules at the apex. That's going to be way too much. I haven't tried it myself. I wouldn't recommend it. But certainly 25 millijoules mid-root is what we typically do. Works quite well, and we do not see these hypochlorite accidents. And this is just a video to show you the enhanced pressure differences of chamber versus canal, and the importance of why we have tips that can be used in the canal itself. I'm going to skip over this one, but it's the same kind of thing. It's just using the tip 1. You can see again here I'm able to place it closer to the apical region, as you can see there. So this is 3 phases of root canal treatment. I like to think of it as debridement, bulk disinfection, and deep disinfection. And you have isthmuses at both the coronal level as well as the chamber level. And then, of course, you have isthmus all throughout the canal system. I have some color coding here of what I think should happen in terms of debridement, bulk disinfection, deep disinfection. We have here tip 3 and tip 2 are more for the pre and post rinses. Tip 2 and tip 1 are more for bulk disinfection and deep disinfection. And I have here basically the techniques and how you typically do this. And as you can see, A is more for chamber, move around the chamber, typically used in the pre and post rinse conditions at a higher millijoules. And then B and C is more the withdrawal stroke when you're using tip 1 or even tip 2. Here again is just a chart showing you 75 millijoules at the start, 75 at the end. These are optional, and you're using water or solutions 1 and 2 or solutions 1, 2, 3 as the different modes on the Edge Pro. And again, color coding to show you where you're placing the tip at mid-root and how you're activating the tip and withdrawing up to the coronal aspect, and then pausing there to continue on with the irrigating to keep agitating the solution. Again, another sort of diagram to show you the technique. Once again, if we start with a lower energy alternative of 15 millijoules and then progress upwards, you can do this in the chamber as we showed in the calcified chamber technique, and then also in the canal as we are decreasing our millijoules, going from the 25 to 15 and doing a loose mid-root placement of the tip and then withdrawing up to 2 seconds millimeters per second up to the orifice level. So here's just the location, just to kind of reiterate where we're doing this, and then this is the tips, tip 3 and tip 2 and 1, and then tip 2 and tip 1 in terms of what we're doing here. I want to show you how important it is to remove calcium hydroxide by doing this technique. And you can see here, this is a continuous irrigation just with saline. And I've placed calcium hydroxide. You can see a little cloud of it coming out. And And that works really well. You do see some splashing, and that's because, we're using, the 25 millijoules, and in this particular case, and when we decrease the energy, you use intermittent irrigation, you can see a little bit less splashing, and you appreciate a little bit more of the photoacoustic effect. So here we're going to just do it again here intermittently right now here. Bit lower energy there, and you can see actually right there a little bit of calcium hydroxide just come right out of there. And this is what's great again, the importance of placing the tip in the canal is just crucial for endodontics. And we can flush it out with a syringe irrigation, and we can repeat. And you can see another little piece there of calcium hydroxide coming out. And we can then use our EDTA solutions, repeat again with that, and flush out even more debris or more calcium hydroxide. So it's important to get rid of that before operating, of course. And so that's the so you can see, I'll just let it play out here. And then we rinse again. It's starting to look cleaner, maybe perhaps a little less cloudy. This calcium hydroxide solution is being has been removed much more effectively. As you can see, the solution's cleaner. And that's kind of what we want. And then we place our cone for cone fit. So ledging in the canal, again, it's going to be more about lower energies. Keep the tip 1 and 2 moving. Recapitulate with rotary files. Make sure it's a loose placement in the canal. Always activate in an outward direction, and make sure you're working in a wet environment with solutions or water. The LAI allows for enhanced tissue dissolution and debris removal and disinfection, and it just takes time to dissolve the tissue, so just be patient. Solutions come out of the canal at 25 millijoules or higher, and that's the reason we're recommending, or at least I'm recommending, the 15 millijoule option. And if you do that, then sometimes the solution, the chamber will go dry, and then you can increase the ledging or ablation potential. There's a workaround, which is the continuous irrigation. And in that case, make sure you just keep your tip loose and keep it moving. I would like to recommend to practice continuous irrigation with saline at first, because it requires your assistant to do a lot of this for you as well in conjunction. But the intermittent irrigation you can flood the chamber yourself, apply the lower energy, and I think have an easier time with this. Bleeding in the canal, I think it's either because there's still tissue left in the canal, or the source is inflamed periapical tissue, and there's a tendency for that to bleed, especially with laser patency that we see more with use of the laser. EDTA may initiate some bleeding as well. Smear layer, an organic or inorganic dentin plug has dislodged. That's a possibility as you're doing your solutions, your final solutions. There could be, after something's dislodged like that, you can have bleeding from a lateral canal, or maybe the periapical tissues, or there could still be some remnant pulpal tissues left in the canal. I like to make sure that I instrument my canal fully with either Hedstrom files and larger canals, and then repeat irrigating solutions with the laser to get the smaller bits. Use of full strength, I believe that I used to use full strength at the beginning of my journey with laser, and found that when I dropped to half the strength at 3 to 4%, I did see less bleeding. So I like to recommend usually just to go down to 3 to 4%. I think that's very effective and it helps a lot. I do believe we should embrace some bleeding. I think that we're decompressing some of these periapical tissues through laser patency, and I think that, and we're also removing tissues just that need to be removed that we thought weren't removed, like little remnants of pulpal tissue that are still hiding somewhere in the canal, somewhere along the walls. So how do I stop bleeding? I generally just re-instrument if I need to, irrigate again, and I'd use my microsuction, just leave a paper point for about a minute in there. And I would say 99% of the time that works real well. Lastly, I'm going to breeze through this, but Dr. Jalali, Dr. Hin, Pali, and Yamaguchi, they use the tip 1 RFT2 tip on mesial molars of mandibular mesials of mandibular molars, and they tried to show debridement of the isthmuses, and they had 2 groups. They had the endoactivator group, and they had the erbium chromium YSGG group. They instrumented at a 2006, and they used 25 millijoule energy setting, the favorite that we use all the time. And they did micro CTs, and they did, after instrumenting, they did an irrigation and then a post-irrigation, and they compared the increase in air volumes. They used continuous irrigation. This is the technique they use for endoactivator. They did bring the tip down to working length -1, up and down motion. And for each canal is 90 seconds. Of course, there's 2 canals in these isthmuses, so the total was about 180 seconds or 2.5 minutes. The total also for that was 4 mLs of 2.5% hypochlorite and 2 mLs of 17% EDTA, meaning that 2 mLs were used per canal and 1 mL was used of EDTA was used per canal. Interestingly enough, here with the erbium chromium YSGG is they took the tip 1 just to mid-root, and they did the same withdrawal strokes as we're used to using the technique. And what you have here is the purple shows an increase in air volume after irrigation. So after instrumentation, they try to keep everything pretty much the same. And now what you're seeing here is an increase in more so in the YSGG than the pro endo activator, in the order of actually almost 50% more. The endo activator had an average of 20.24% increase of air-filled space, and the erbium chromium YSGG had a 37.37 average increase in air-filled percentage space. So again, the conclusion here is that we basically have a laser group comparing the sonic group is more effective in removing debris in minimally instrumented root canal systems, such as in the isthmuses using a 2006 mass rate pool file. I think this is, so going back to it real quick, I think this is a really important study in that it shows what the laser can do. And what we're trying to do is clean these isthmuses that I think is still sort of like what I like to think is the last frontier in the tooth. Well, dentinotubules can also be that, but it's really more the deep disinfection that we're looking at. And it's isthmuses both at the coronal level and at the mid-root and apical levels that I think are still lacking in our endodontic treatment. So just a summary here, effect is greatest at the tip. Boundaries make a difference, whether you're in the canal versus the chamber. I showed you that in the video. Placing tip in the canal is important. It's better for calcium hydroxide removal and debriding isthmuses, as I showed you in the video. And Dr. Jalali's study here published in the JOE. Take your time, of course, be patient, keep smaller tips moving. This is kind of like a reminder that we're using laser activated irrigation. We're allowing the irrigating solutions, mainly the 3 to 4% hypochlorite, to do most of the action here to dissolve tissues. So you're just using an amazing tool as a laser to agitate those solutions and get where you need to be to move debris and disrupt everything. Remember the 3 phases of treatment, debridement, as I like to call it, bulk disinfection and deep disinfection, and use the tips accordingly. Intermittent irrigation with lower energy, 15 millijoules, can increase lasing time and decrease ledging and bleeding. So I recommend that you try this setting for you. It's a 0.3/20 hertz, and air and water is off. And I'd like to just give it a try. That by all means does not, I don't mean don't stop keep using your continuous irrigation at 25 millijoules. I just want you to give the 15 millijoules a try with some intermittent irrigation in this case. Conclusions, why practice laser dentistry? Well, it makes your life easier and it makes endo easier, and that I think is worth it just alone. So my email there, if anybody has any questions for me, be happy to answer any questions right now, or if you can think of them, I'll be happy to email you back or get in touch with you to answer them. And I thank you very much.
Thank you so much. We do have a few questions that came in while you were speaking, so I'm just going to start from the top. And if you have already spoken on them, I do apologize. But the first question that came in was, in the pulptus cases with hyperpemic pulp, what is the recommended application? And then what solutions, wet or dry, settings, tip placement? So 2 questions in this. What is the recommended application? And then some of the solutions.
So I think it was hyperemic pulp, so there's too much bleeding in the canal, I believe it is. Okay. And tip placement. Again, I'm a firm believer that it's just you got some remnant tissue inside the canal somewhere, and we work on some very inflamed teeth sometimes where the periapical tissues are just really, really inflamed. And maybe we didn't appreciate it so much before, but we have this thing that's very real, which is laser patency, and you can dislodge, you know, a piece of debris or an organ or smear layer that was plugging up your apex, and all of a sudden you have a rush of blood coming through. I think that this is something that we're just going to have to kind of welcome a little bit, but I would go back to removing most of the tissue. Sometimes there's just a hunk of tissue in there, and if you just take a headstrom file and like a larger headstrom, I'll even bend even 30s and 35s at the tip, and just kind of twirl them around inside in the palatal canal or the distal canal of larger canals, and I'll be surprised that I'll get a piece of tissue out of there sometimes when I thought everything was gone. And then after that, I leave the laser to do the little bits, basically. So having done that, and maybe spending more time with the laser and the irrigating solutions, I find that that at the very end of the case, it doesn't bleed much, and I can just place my my paper point in there as needed and just fill the case because I don't have profuse bleeding.
Wonderful, thank you. So we have another question here, and it was, which tip are you typically using when you use the 15 MJ setting?
So I'm using all tips in this case. What's nice is that I want you to try that setting with your in the chamber with the tip 2 would be a great one. Tip 3 as well for managing those calcified canals. If you want to also do what we call coronal conditioning or just kind of clear the chamber, and if you're not just necessarily looking for canals, but you just want to clear of debris, you can go ahead and do it there and just do your syringe irrigation and suction afterwards and repeat. Tip 2 is great for that as well for chamber. If you want to then go into the canal, again, tip 1 is great for it. What I found is if I use 25 millijoules in an intermittent irrigating, scenario, I do feel that the solution still can come out of the tooth quite quickly, and then I have to replenish it pretty fast, and then I have to resort to continuous irrigation, which I don't have anything against. I'm just saying try this as that the whole presentation is just try this at a lower energy to see how you like it. And I think it'll increase the amount of time that you're agitating the hypochlorite solution in the canal without having to resort back to the syringe irrigation and repeat back and forth so much, so much more frequently as you would if with higher energies.
We do have a couple more questions, but since we are at the top of the hour, I just wanted to quickly share that verification code that we spoke about earlier, first and foremost. So you'll see that on your screen right now. I'll put it in the chat box for you as well. It is just, it is case sensitive, but it is RHJV6XN4. As a reminder, you'll return to your CE Zoom accounts, find tonight's course under scheduled live courses, click that verify button, enter the code both in the chat box and on your screen, and then you'll take a survey and your certificate will be right there. We just ask that if you have any problems with this or any questions, you reach out to us directly at CE Zoom. It's just help, help@cezoom.com. So that is the code for you. And then, like I said, we do have a couple more questions, but I would also like to share this. And Greg, if you would like to come back and discuss any of this, if you want to get your phones out now, there is a QR code here for you that Greg can explain a little bit more of.
Great, thanks, Tori. Hopefully I'm popping in here. Thank you, Dr. Meza. Yeah, please go ahead and use this QSR code if you're interested in scheduling a demo, or contact us directly, and we can help get a rep to you to answer further questions. I do want to turn it back to a few more of the questions that are on here, Dr. Meza. I think there's a few doctors that have a few questions. One of them was, is there a way to change the settings on the Edge Pro? Maybe you could talk a minute about Endo Geek mode.
Yeah, so in Endo Geek mode, I had that one slide that so you can, so I kind of found the ranges of the limits. So I think 10 millijoules is the lowest I believe it can go, and then 100 millijoules is the top range. And as you move the millijoules up and down, sometimes the the unit will sort of change up your watts depending. And so there's certain configurations that allow you to put certain settings, and so there was kind of like this idea where I guess it jumps up every 0.125 every time. That was just my way of like understanding the intervals or the common differences. But I will say this: a higher hertz setting allows for faster fluid movement, and I like to think of it as like in boxing, like little jabs, versus a lower hertz, like a 20 hertz, is more like an uppercut. It's just like deeper cuts or deeper punches. And so I feel like more energy is being emitted in that pulse versus little jabs where the energy is sort of distributed in those smaller jabs within that second. At least that's how it feels and that's how it looks. And so it is a bit different, even though the millijoules can be the same. It's just how they're basically released basically through the laser pulse, or they're in that 1 second different hertz. So
A few
yeah.
more, just a few more questions just to try to get these covered. Some people are interested if you've tried Triton versus sodium hydrochloride and LAI.
Yeah, I'm excited to use that actually. I mean, I've heard amazing results with using Triton. I haven't used it much recently. I haven't used it much lately or initially here, but I think it'll be great to use. I think like I said, agitating solutions is what's important here, and you have a perfect tool to do that in almost any canal, configuration, whether it's a large canal or a small canal, and you have all the tools to increase energy, decrease energy, and so I think it just can be amazing to use it. Yeah.
So an experience question, do you often experience apical extrusion of solution during activation and any associated patient discomfort? If so, how do you avoid it?
So if I do I haven't had an extrusion of hypochlorite ever since I've been using the laser. I think it's because we're very careful to use that range that I've mentioned in some of the slides. Is in the canal, it's like a 16.7 millijoules to a 50 being closer to the coronal aspect of it. I also use 3% hypochlorite. It's a little bit less, but so I haven't had any accidents ever, thankfully, knock on wood, I guess you could say. But haven't even heard of any accidents either using laser. The other thing is, so I have had on occasion a patient kind of feel vibrations a little bit more, and those used to happen when I would work even at higher millijoules, like 37.5 millijoules perhaps, and when I dropped them down to 25, a patient wouldn't feel them anymore. And so in this particular case, if you feel like the patient's feeling something at 25 millijoules, try this 15 millijoule setting and see what comes out of that. In the end, it may be that you just need to flush out the solutions and either give an intrapulp or just give a palatal or just give another anesthetic. But it's rare for me at this point using the technique, especially the lower energies, to have a patient not tolerate the laser. So it's very rare. Yeah.
So it looks like two more questions. One of them is there any evidence to use different settings with EDTA versus sodium hydrochloride?
I haven't heard of the importance of different settings per different solution. I think that what's important to me is that the solution remains in the chamber or in the canal as you're using it. When you flood the canal with your syringe irrigation, you want to make sure there's no air bubbles. And an easy way to do this is under microscope is to put the tip of the needle right on the pulpal floor, but not, of course, not in any of the canals, because then you'll just deliver, you'll create a hypochlorite accident. You want to put it on the floor itself, and there you can sort of start to inject some of the solution on the floor, and you'll see the air bubble come up to the surface. So that's one way to get rid of an air bubble. But if you're not doing continuous irrigation, you have a situation where you activate the laser in the canal, and then if the energy is too high, the solution goes out. And so I think it's really more important about spending more time with the solution, agitating it, efficiently, and for a longer period of time, which is allowed with this lower energy setting that I use.
Dr. Meza, we appreciate your time. One last question. With intermittent irrigation, how many times do you typically go down the canal with tip number 1? And is there any difference between vital versus necrotic?
No, I like to do it the same for both. You think in your mind, well, I'm trying to get these small little bits that lateral canals, maybe or isthmuses of tissue, you know, those kinds of things. And then with the necrotic cases, you're thinking, well, the isthmuses are loaded with, you know, necrotic debris or bacteria. And so both, I think, come to mind. But I will say that I typically can go, you know, just in that Jalali, you know, they did it study. They went in there basically 30 seconds per canal. Sorry, 90 seconds per canal. And so I typically go maybe 20 seconds, and then I may then instrument a little bit more, go 20 seconds again, you know, instrument a little bit more. And then for my final rinses, I may go 20 seconds or 30 seconds even as my final rinses, and then switch to the EDTA, do it again for 20, 30 seconds, then try my cones, and then go back again for maybe one last sort of 30-second, you know, activation of the canal. So.
All right. Thank you, Dr. Meza. Thank you, everyone, for joining. This concludes our session. Thank you.
Thank you.
Have a great night.
You too. Thank you.